Thank you, Artie. Thank you for the invite to be here. Wasn't sure if I was going to show, so these would be my disclosures. I chose this topic because in my many years in dealing with drug or finding my way into drug safety, I was fortunate enough to hang around with a lot of the world's greatest experts in infectious disease and opportunistic infection, and I've always heard this message about pneumonia being the big problem, and it was sort of the big player. We're going to begin with a question, but first you should know that pneumonia kills about 50,000 Americans every year. It's estimated that up to 1 million people will be hospitalized with pneumonia annually. Maybe an equal number or half that number will be outpatient pneumonias, well-documented outpatient pneumonias. So it's highly prevalent. The question is, who in this list has died from pneumonia? Number 1, Harpo Marx. Number 2, Don Henley. Number 3, Ginger Rogers. Number 4, Sir William Osler. And number 5, Bing Crosby. Answer now. And there is a right answer. Not coming up? So this is a poll question. We'll give it a second. Is it not working?
No, nobody's.
All right, good. We're ending the day as we begun the day. The right answer is the person who used to call pneumonia an old man's friend, and that would be Sir William Osler. He himself died of pneumonia, noting that pneumonia was the easy way out as elderly people went on in years. It wasn't Harpo Marx, it was Groucho Marx. Don Henley is alive and doing very well, thank you. Glenn Fry from the Eagles did die of pneumonia. Ginger Rogers, no, but her dance partner, Fred Astaire, did, and not Bing Crosby, but Bob Hope died of pneumonia. So that's your right answer. So this is, obviously there's a spectrum of lung disease, and you must consider that the lung is probably maybe one of our biggest immunologically active organs. If you think about the alveoli and all the cells and the immunologic activity that goes on there, it's not surprising that a lot of disease begins and ends in the lung. The spectrum of lung disease is really quite large. It affects up to 60% of rheumatoid patients will have some degree of lung disease, with probably the most prevalent of these being interstitial lung disease, and that's going to be talked about in the next session by Jeff Sparks from Harvard. In lung disease, bronchiectasis, organizing pneumonia, we're going to really talk about infective pneumonias today and its impact and relationship to rheumatoid arthritis. So again, it is the most common, especially bacterial infection, that will affect RA patients and put them in the hospital. Again, the major comorbidity in RA that leads to all poor infectious outcomes, including infectious death, is lung involvement. And I'll show you where that stands in relationship to everything else. This is basically community-acquired pneumonia happening in a specialized population, and in the general population it accounts for about 50% or more, and it's the same in rheumatoid arthritis. As I said before, it is the #1 cause of SIE, serious infectious events, but SIE is leading to death even more importantly. Again, the mortality rate for an RA patient who develops hospitalizable pneumonia is 12.5%. It goes up if you're in an ICU. It goes up if you're elderly. It is more likely with higher levels of disease activity. It's more likely if you're seropositive. And the interesting thing is that the risk of serious infection and pneumonias has actually decreased in time. That's shown here on the next slide. This is from the U.S. National Inpatient Sample. It's hospitalized patients. Looking at 2000 and 2014, there's an actual decline in mortality for those who are hospitalized from 76 to 30 per million by 2014. In this period, pneumonia, and the graphic looks like things are going up. This is the relative percentages of why people died if they were hospitalized. You can see the yellow bars actually go down over this 14-year period. Those are deaths due to pneumonia. And basically everything else is the same or going down a little bit, But the blue bars on the top of the stacked bar, the light blue, that is sepsis. The percentage of sepsis has gone up from 1.9 to as high as 7.9%. And whether that's real or not is unclear. There's some consideration that it's a coding issue. A lot of this data deals with ICD-9 codes and getting reimbursed properly. So again, maybe there's a little bit overuse of sepsis, but there are other lines of evidence saying sepsis is the infection that is going up and killing people. To consider and understand pneumonia, you need to understand pneumonia in the general population, not in rheumatoids. So that would be called community-acquired pneumonia, or CAP. This is, I think, a very important study. I've shown it before to many of you. It's 11,000 elderly people over the age of 65. Again, there's no RA, there's no arthritis here. And the question is, what leads to them getting pneumonia? And the rate just in the elderly is 14 per 1,000 patient years, and that's an important number. If you are, again, everybody here is elderly, but if you happen to also be immunocompromised, that number goes up almost threefold. If you have chronic lung disease or you're on chronic long-term steroids, that goes up almost fourfold. And this is important when you consider, again, does this apply to RA patients? Well, again, for those patients who did develop pneumonia, the fatality rate was different depending on whether you're an outpatient pneumonia, which is about 1/3 to half in some cases of all pneumonias. Inpatient was 15%. If you're ICU hospitalized, chance of dying was 40%. Now, I like to show this data juxtaposed to data from Fred Wolf in the National Data Bank, and that's shown here. His study of 16,000 patients showed that the average number of pneumonias in a rheumatoid population is 17 per 1,000 patient years. And yes, you have the same 2 to 3 to 4-fold increase in this event rate based on whether someone's older, on steroids, or having comorbidities, including lung disease as a comorbidity. So pneumonia, the risk is driven by age, severity of disease, steroids, and comorbidity. So if you compare what happens with pneumonia, there's two studies I have here. One is a single center study of 71 RA patients versus control. The other one's a larger population study of 1,200 RA patients versus 5,200 controls. The bottom line is that the risk factors for pneumonia were age, being female, having underlying disease, which was seen in 72% of patients. If you had underlying disease and RA, you were less likely to receive methotrexate and biologics, meaning those were not the factors that led to someone getting pneumonia. Steroids and immunosuppressive use was a risk factor in this one study. What about the mortality? The two studies had two different outcomes. The first study, the smaller single-center study, showed that RA patients had more deaths, 11% versus 5%, and more likely if you had pre-existing lung disease. So they surmised that RA itself was an independent risk factor for mortality in patients who developed pneumonia. The second study showed RA patients overall did not have a greater rate of mortality. However, when they had a high CRP of greater than 20, it was a 5-fold higher risk of mortality. If they were on prednisone, it was a 3-fold risk of mortality. Now, are they on prednisone and on high-dose steroids because their pneumonia is really bad or because their RA is really bad? They didn't go into that, but those clearly seem to be recurrent themes. There are other risk factors that come up. Seropositivity. This is actually one of these studies. The one on the bottom right is actually from Jeff Curtis from ACR this year. But the interesting thing about pneumonia and seropositivity is that we do have lung involvement that can lead to the generation of autoantibodies. There's some preclinical RA studies of patients who don't yet have RA, but one, they have inflammatory activity in their lungs, and they generate CCP antibodies and rheumatoid factors also from what's going on in their lungs. The question I'm going to pose that's a little different than that is for people with disease, being rheumatoid factor positive with RA, does that get you more pneumonia? And the answer is yes. And interestingly, not CCP as much as rheumatoid factor. So in this particular study that Jeff did, it's a cohort analysis, he showed a 2-fold higher risk, an adjusted hazard ratio of 2.15 when you were rheumatoid factor positive. CCP did factor in there, but it didn't seem to add much to the story. Moreover, patients who are seropositive have a higher risk of dying from pneumonia. So this is looking at the risk of death in nurses' health study and what caused that. You can see, obviously, if you had lung disease and you were likely to die, a pulmonary mortality, but also almost as high was being seropositive for rheumatoid factor as opposed to being seronegative. So seropositivity seems to play a role. Maybe it reflects the severity of RA. So the question then becomes, there are other factors. We know smoking is a risk factor, right? So what about, and most of you are actually quite good at counseling your patients on smoking, but if they do quit smoking, are they afforded any protection? So the question is, if the patient has quit smoking 30 years ago, is the risk of incident RA no longer increased? We do know smoking increases the risk of developing RA. So this is another polling question, true, false. Answer now. Let's see if this works. Oh yeah, there we go. The polling woke up. So you've been off cigarettes for 30 years. Do you still have a risk of developing RA? Survey says?
It is like 50-50, almost. 52 true.
That's a fabulous question. Fabulous question. And I'll tell you the answer right quick, as we say here in Texas. The answer is false. There is improvement. Things do get better, but you never fully resolve that risk, even though you've been off of it for 30 years. So we do know that smoking is a risk factor for developing RA. We do know that smoking is a risk factor for more severe RA, and that goes to, again, the shared epitope and the role of smoking in patients who are CCP positive with the shared epitope. Patients who have established RA, you'd think they would be smart and not smoke. Wrong. Established RA patients actually have a 50% higher incidence of being current smokers. And that's a reason why you always have to ask about smoking or look at their fingernails to see if they have smokers' fingers. Obviously, again, smoking will increase the risk of hospitalizations with a subsequent risk of cardiovascular and respiratory outcomes. And then what happens? If you stop smoking, there's good data that patients will improve their PFDs, will improve their survival numbers. In RA patients who stop smoking, it does lower disease activity. It is a measure for lowering, and it's not right away. It does take, really years for that to happen, but not too many years. For each year off, there's a 15% or 25% less risk of respiratory or cardiovascular hospitalizations, respectively. And like I said, if you quit 30 years ago, it does lower the risk of getting RA by 37%, but it never truly goes away. You have patients with COPD in RA. This is also bad. The bottom line being pre-existing lung disease puts RA patients at a perilous situation. Bad things are going to happen. They're going to have more infections and more bad outcomes. This applies to both asthma and RA. The graph on the upper right really shows you that patients, basically everybody here in all these studies, have an increased risk of an association, RA patients having COPD. So that's out there. What happens when it comes to RA and COPD? It's estimated somewhere between 6 and 10% of RA patients will have COPD, and then they themselves will have a higher risk of hospitalization, of pneumonia, and by the way, that's not really affected by background therapy, including the more aggressive recent therapies. And clearly a higher risk of death, shown here on the bottom right. The patients who are COPD positive compared to those who don't have COPD, they're much more likely to die, and again, a 50%, 60% higher risk over the next 10 years if they have COPD. So we mentioned before that, that there are risk factors for serious infectious events, and the number one would be pneumonia. The best predictor of those is, first, RA activity. And by that I mean inflammation as measured by a CRP or measured by many swollen joints. It also includes debility. And this is the prime driver of infectious risk and also of pneumonia. Steroids, as we've said, and I'm going to show you, in any dose is a risk factor. And then comorbidities. We always talk about comorbidities, but the biggest one is chronic lung disease. In any form, BOOP, COPD, ILD, it doesn't really matter. This is the bad one. This is the one you really need to worry about. Heart failure, diabetes, yes, we all know about that. The skin, when you break it down, you get more ulcers, more wounds, surgery, you open up the skin. Skin is your number one barrier to infection, not surprising. The bottom line is that there's very little risk imposed by our biologics and newer drugs and even conventional DMARDs, but yet when someone, an RA patient, on a JAK inhibitor is admitted to the hospital and dies, everyone says, oh, he was immunosuppressed. No, it was the RA. It was the 11 milligrams of steroids. It was, having an open, malleolar ulcer and then having background COPD that killed the person, much more so than the drug. But there is a role for the drugs in causing pneumonia, and we'll review that in the next slide. First, this data from Paul Emery, which I think was very instructive, going back almost 10 years now. It's from the British Biologics Registry, and he showed comparing patients in that registry on either a DMARD or etanercept. The graph on the right says it didn't matter which drug that you were on, that you had an increase in the rate of serious infections based on the increase in the DAS score. And it was the same for DMARD and etanercept. So the biologic didn't make it any worse here. And for every 1 point increase in DAS score, so a DAS from 3 to 4, there was a 17% increase in the risk of serious infectious events. Very instructive to underscore that point. I think maybe one of the papers of the year could be this paper in Annals of Internal Medicine. It comes from Jeff Curtis and George and colleagues, where they analyzed 2 different databases, both a commercial database and Medicare database. Over here, it's Medicare on top. Over here, it's the Optum database. And you can see over here, patients not on glucocorticoids, the rate of hospitalization for infection was 8.6%. If you're on glucocorticoids, any dose, it was higher than that. And then when you look at the forest plots, the bad news is, compared to none, patients on 5 milligrams have a higher risk of serious infectious events and hospitalizations. Okay, and this, again, most of this is all pneumonia. So again, we need to worry about steroids at any dose and get to as low or maybe none when it comes to steroids. So you all see this patient. This is actually another polling question. What is the risk of this patient developing an SIE like pneumonia in the next 12 months? 62-year-old female with COPD and prior pneumonia has been treated with 6 prior DMARDs or biologics, now has 6 swollen and tender joints. It has a HACO 1.2, taking leflunomide and 15 milligrams of prednisone. In the next 1 year, what is the risk that this person is going to develop pneumonia? You can answer now. It's either 1, 3%, 2, 7%. 3, 15%, 4, 28%, 5, 39%. So let's see what the audience says. And I'm telling you what their risk is right now on those drugs. Okay. Everybody liked the lower ones, but you're pretty much split, which means that only 22% of you are right. Oh, actually, I think it's 9%. I can't remember. Let's go to the slide. The answer is number 4. 9% of you are right, because the right answer is 28%. This data comes from the Rabbit Registry. This is in the Rabbit Registry calculator where you can calculate your patient's infectious risk for pneumonia or a serious infectious event in the next year based on a few factors. And again, they developed this on over 10,000 patients and then tested it against another 10,000 patients and verified that this in fact works. You can predict the outcome based on the age, use of prednisone, the number of prior DMARDs, prior SIE, meaning do you have a prior pneumonia because you're likely to get another one next time around, and current biologic. You can see that in the next 12 months, this patient on top has a 28% chance of developing pneumonia. Now, you put this patient also on a TNF inhibitor, it goes up to 45%. This is the scenario where adding a biologic will increase your risk after all the other bad things are in play. And that is shown here from also their data. And just look at the first row across the bottom, the gray bars. And they have 3 groups, steroids less than 15% or 7%, then 7 to 15% in the middle, and then greater than 15%. And there really is not much difference. If you add in a biologic, which is the second of the two of the pair, there's almost a little bit of a doubling there. And so it's inconsequential in people who have no additional risk factors. But add in additional risk factors. And that's age, lung disease, renal disease, number of prior treatments and prior serious infections, and go to the back row in maroon there, and now you add a biologic in, and this is where the risk takes off. This is where the guidelines aren't helpful, because guidelines tell you the patient had a prior SIE and what you should do when they're really sick. They tell you not to use a TNF inhibitor, but who's to say that they're not going to do better, or they're going to do better by being on a triple DMARD therapy, which may not control the inflammation, and inflammation also drives risk. It's really complicated. I'm not saying there's a right answer here, but it's not so quickly answered by the guidelines. And there are other pneumonias. I just want to keep you to keep in mind that there's a lot out there about other pneumonias. Pneumocystis, there's a lot written about it, although I'm sure in this room we might have 2 cases amongst the 40 rheumatologists who are in the room and the 300 who are at home. Then we might have a few, but it's very uncommon. I'll tell you the risk factor for pneumocystis amongst RA, the number 1 risk factor is rituximab use. So those are the patients who you should have in the back of your head. Rituximab, this could be a PJP infection. It is more common in certain areas of the world. It's thought there's some data out there saying being on sulfasalazine and maybe hydroxychloroquine can lower the risk. I do not advocate our patients should be on, including patients on rituximab, should be on background anti-infective therapy like with Bactrim. But if someone's at high risk because they have other risk factors, then maybe that does make sense. The number 1 non-TB opportunistic infection, and even bigger than TB, is non-tuberculous mycobacterial infection, what we used to call atypical mycobacterial. In every study I've ever seen, whether normal people, cancer patients, RA patients, those are more common, much more common than TB. And you should be working those people up or considering that diagnosis if you're considering TB. Fungal infections, in the pre-learn, there was a nice map of the histobelt from Ohio down into Texas and Arkansas. Coccidioido in the southwest where Artie is, again, it's pulmonary, bone, lung, skin. There really aren't great tests for it. It really has to be a clinical diagnosis, so supported by culture. The antibody testing is not that good. There's Legionella, there's also nocardia, and there's also, drug-induced pneumonitis like methotrexate, but that should not be hard to identify. So here's another case for you. A spontaneous pneumothorax, 48-year-old male with established RA, stable on methotrexate and etanercept, and also 5 milligrams of prednisone. He's really doing quite well, but over 3 months he has 3 sudden ER visits for acute shortness of breath. In the ER, each time he's diagnosed with pneumothorax, either by chest x-ray or CT chest, and he has to have that treated and whatnot. What is the cause of his recurrent pneumothoraces? Let's answer this one now. Number 1, emboli. Number 2, TB. Number 3, nodules. 4, methotrexate-associated lymphoproliferative disorder. Or 5, RA lung or RA-ILD. Please answer now. Okay, my partner and I managed this a long time ago. We actually treated this with Cytoxan and Lord knows what we used in another agent in addition to Cytoxan. This was pulmonary nodules. Actually, it was rituximab is what we used. I just remember that now. This is pulmonary nodules, and they would erode actually into the alveoli or into the bronchi and cause recurrent pneumothoraces. It's been very, very well documented for this to happen. The treatment of this, no one really knows, because how do you treat pulmonary nodules? Well, here's a short study from the Mayo Clinic, and they basically showed that their patients with lung nodules tend to be a little bit younger. They tend to have nodules elsewhere in the body. They often are seropositive. And on CT, they have their appearances such that they have smooth borders. There are many of them. They often cavitate, and they often are in contact either with the pleura or the bronchi, and they erode into them, and that's how you get these thoraces. How you treat it, there is no standard of care. I'd like to hear your answer as to how you treat it. Pneumonia, the considerations, and this is really for you to review. There's nothing magical here. I think everyone should be evaluated for pneumonia, obviously with any kind of progressive symptoms. I want to make a strong point for anyone who's had a past prior serious infectious event. A hospitalizable infection like pneumonia is more likely to get it in the future, and that applies to the general population. That really applies to your rheumatoid arthritis patients. They're at much higher risk. and you have to worry about those patients. Disease prevention, I don't think there's a role for prophylactic antibiotics. I do think that there's a role maybe in vaccination, and there may be certain avoidance strategies that might actually work. The question is, does vaccination work? And this is the ACP guidelines on how to use the two pneumococcal vaccinations, either PCV13, Prevnar 13, or PPSV23, the Pneumovax. A patient who is immunocompromised should first, and never received either of these, they should first receive the PCV13, and then you wait 8 weeks, and then you follow that up with the Pneumovax, and then you give your second Pneumovax 5 years later. What if you're someone who received Pneumovax first? Well, then you have to wait a year before you get the PCV13. And then between PCV13 and the next PPSV23 or Pneumovax, it's got to be at least 8 weeks, but then at least 5 years from the first Pneumovax. A little confusing, but leave that up to the CDC and the ACIP to really confuse us. But the bottom line is PCV13 first, and then the Pneumovax 8 weeks later. Does it protect? There's three studies here. Two say yes, one says no. It's very hard to do studies that prove that that you would get protection from the infection you're trying to prevent. Number one, it takes time, and two, it takes an incredibly large number of people. So like these recent vaccine studies with the COVID vaccines, I think are incredible. Again, if you're just going to prove it by seroconversion and immunogenicity, those are easy to prove, and that's why these drugs are in fact on the market. That's why, in fact, the COVID vaccines got on the market so quickly. Does it prevent pneumonia? This one study down here on the bottom with over 500 patients shows over a 50% protection. That bottom line is the risk of getting the infection was down to 0.47. That's a 53% protection. This is a slide that I took from T-Reg and our work at T-Reg a few years ago that this has also been published, and it looks at what happens when as far as getting serious infections or non-serious infections. And what you need to do is look at the SPA and the RA lines, look at the yellow dot and the orange dot. The orange dot is someone vaccinated with the pneumococcal vaccine, just one shot, and that's going to be Pneumovax. And you can see that there is an edge, there's a trend towards improvement for those who were vaccinated with the Pneumovax, especially with regard to serious infectious events. So I'm going to end by saying if you have RA, bad things can happen if you also happen to have, comorbidities, age, you're a smoker, you've got chronic lung disease. Now you're onto this cascade of a risk of pneumonia. And the risk of pneumonia gives you a risk of hospitalization. And the hospitalization, the odds are really stacked against you as far as death. All of that's covered tremendously by your amount of disease activity and by your background of steroids. Oh, by the way, the same scenario that applies to all your RA patients applies to all your patients on COVID. And what happens in this case of COVID? It's really the same scenario. The patients who do badly with COVID are the ones who have the background comorbidities, the ones who have activity, the ones who are on steroids. And I think that's the take-home message. Again, I'll end with COVID because that's kind of where we are today. Recognize that in the pandemic that happened almost 100 years ago, the primary cause of death was in fact pneumonia. And we know from what Philip Robinson just told us that our patients are done very well. We have to worry about age, comorbidities, and steroids, but if anything, most of our therapies do not seem to factor in. It seems like TNF inhibitors and JAK inhibitors in the early reports look like they may have better outcomes. In the updated reports, look like there's really no benefit per se, but really no harm. Steroids, there is a harm, and as Philip indicated today, there's a question about being on no therapy, being on sulfasalazine, or being on rituximab as far as the risk of COVID pneumonia. So these are the risk factors that you should always keep in mind in dealing with this. Thank you very much for your attention.